your seniors, are they going to? So urine, to screen for UTI, that's what they have. It's very easily treatable and they can go on their way. Any blood in the urine, especially if they're elderly or if they smoke, if they have any risk factors for bladder CA. And gynecological causes, surgeons are notorious for. So the hospital I'm working at, there was a rule made after actually a patient died. It was supposed to go to, it was refused by the surgeons. So in the hospital I'm working at, Sandwell Hospital, they essentially said any abdo pain goes to the general surgeons, regardless of symptoms. So it's one of the changes they've made. And, it's not very popular with the surgeons there, because they get all sorts of things. So thorough history does help them over there. Whether or not they can shift the patient anywhere else. So gynecological, symptoms such as painful periods, heavy periods, PV discharge, and last menstrual period. Right. And the other sort of constitutional symptoms such as weight loss, loss of appetite, any fevers, night sweats, things like that. Right. Any previous, investigations on what their findings were, whether they had an OGD, any, colonoscopies or flips and SIGs. What would be important if they had any previous surgery? Adhesions, right? Okay. And all the other components of the history are important as well. Past medical history, as I said, any surgical operations, any medical conditions that would be concerning whether or not they need an anaesthetic review, if they were going to go to surgery. Yeah, COPD, things like that would and they'll be elderly as well. They'll have a lot of comorbidities which may or may not sway the surgeon not to take them to theatre. Any drug history, any NSAIDs related to hepatic ulcer disease, drugs which can cause acute pancreatitis, which we'll go on to talk about, and obviously acute pancreatitis with alcohol and social history. But yes, surgical cartings are usually very brief, and you can get most of the information and move things on very quickly as compared to medical. Right, so we were just mentioning about causes of acute abdomen. They can be either categorized into the surgical SID, which is this, or the, in terms of dividing up the abdomen into quadrants. So intestinal, those are your internal organs. Appendicitis, which is sort of appendicitis organ. Hepatic ulcer disease, diverticulitis, obstruction, which we'll go on to talk about, and a strangulated hernia. Of those, the ones in bold, so acute appendicitis, perforated hepatic ulcer, intestinal obstruction, depending on how severe it is, and a strangulated hernia would warrant a trip to theatre, semi-urgently. Hepatobiliary, so that's your gallstones, inflammation, cholecystitis, cholangitis, and pancreatitis, which we'll talk about as well. Vascular, very important, ruptured AAA. It's always bear that in mind. That is the one thing that you just cannot miss. And if you're worried about it, then you can always ask for CT. Usually those patients come in very unwell. They're tachycardic, hypotensive. They look like crap, basically, shocked, they're sweating, and that obviously you would take them to theatre in that case, especially if they're complaining of central abdominal pain radiating to the back. Okay. Next, neurological. So just ask for a urine dip. Just what type of pain is it? Where is it radiating to? Which will help you know your main differential of renal stones. Testicular torsion, which is important as well. That will run a triple theatre as well. And essentially with that, you get. Does anyone know what would you find on examination on the testicular torsion?
Well,
yeah, I'm not sure about that. But lots of premasteric effects and high-lying testes. Gynecological, one thing is the ectopic pregnancy, which any woman of childbearing age just ask for a HCG and ask them if there's any possibility that they're pregnant. Okay, and medical causes such as a pneumonia, MI, can mimic pain in the abdomen with diabetes, the classic thing that they describe in sort of silent MI. Right. Now this is the other way of doing it. Divide it up into quadrants. Essentially, the upper part of the abdomen is all the organs that are there: the liver, the gallbladder, the stomach, pancreas, spleen, and then as you go lower down, you have the abdominal aorta centrally, right and left, your kidneys, could be a sigmoid colon, cancer, and then lower down, your appendix, terminal ileum, which is associated with Crohn's, and then you have your gynecological pathology there as well. And if they have any suprapubic tenderness, definitely thinking of a UTI or a stone there. Okay, just very briefly, the physiology of abdominal pain. You have visceral pain, which is pain originating from the internal organs. And now the important thing to know about that is that it's poorly localized, it's dull in nature, and it's rather vague. And this is because of the embryological structures from which the internal organs are derived from. So I think from the esophagus to the first part of the the second part of the duodenum is derived from the foregut. So any structures, so esophagus, stomach, pancreas will go to the epigastrium. The midgut, second part of the duodenum, all the way to the transverse colon, paraumbilical, and hindgut will be everything else past the transverse colon. The somatic pain, that's when, classically the peritonism, it's very sharp in nature, very well localized, and patients are exquisitely tender. Has anyone seen a peritonitic abdomen? A truly peritonitic abdomen? Okay. A lot of the pain, a lot of the abdominal pain you're going to get is, they're very, mildly tender, soft. But once you see a peritonitic abdomen, you never forget it. Massive bellies, distended abdomens, you just put a light touch onto them and they're screaming in pain, you percuss and percuss for tenderness, and they will jump off the bed with pain. And that's an emergency, which will, the peritonic abdomen, which we'll talk about. Okay, and the third pain, you can get from cholecystitis coming up to the shoulder blade or to the scapula, I'm not too sure. Okay, so peritonitis is inflammation of the peritoneum, which may be localized or generalized. And peritonism refers to those specific features found on abdominal examination, which are, please mention, lying very still, exquisitely tender, can be local to one area, or it can be just generalized, and if it's generalized, you see a massive abdomen. And it's a surgical emergency, immediate resuscitation, investigations and management, and let your reg know as well, because they usually come and save the day. So, causes of generalized peritonitis, infective, as you can guess, bacteria within the peritoneum that can occur post-op after a leak. That's one thing surgeons do not want against their name is a leak. If they find out someone, if the patient is querying an anastomotic leak, the first question they ask is, "What did I operate?" And if they didn't operate, then they don't, it's not them. It's not. It doesn't come back to them. But if they did, they usually have a shock, face of shock on them. So non-infective causes as well. That's usually just sterile bodily fluids that will become infected within within 1 to 2 days, and that can originate from anywhere: blood, stomach, bile, urine from pelvic trauma. So, okay. Clinical features I've mentioned: is pain, constant and severe, worse on movement, so they're lying very still, shallow breathing, and if it's localized, it will be in a single area. And if it's generalized, obviously it will be massive abdomen, and really you won't forget it. and with a board-like rigidity, very tense abdomen. Okay. So signs of ileus, usually after surgery, the bowel's going to strike, and there are other causes of obstruction which we'll go on to. Small and large bowel obstruction is how they categorize it. Small bowel, usually vomiting, distension, colicky abdominal pain, and tympanic abdomen with reduced bowel sounds, which we'll talk about later as well in terms of bowel sounds. So signs of systemic shock, which I mentioned, the AAA, tachycardia, hypotension, low urine output as well. And again, it's more common with generalized than localized peritonitis. Okay, so these, as I've said, they just look ruddy, they look so poorly that you know that something's wrong. So hints on the type of pain for your exam questions. Any associated back pain, you must rule out AAA, pancreatitis, and posterior duodenal ulcer. Posterior duodenal ulcers, essentially, they erode. I don't know the name of the artery, but there's an artery that they erode into when it's placed on posteriorly, which basically they just bleed like hell. So that's the concern with duodenal ulcers. If they have any sacral or perineal pain, it could be a perineal abscess, and it could suggest pelvic pathology, gynecology causes. Right, so the bowel sounds which I was mentioning, present, they're normal. If they're absent, then you would be worried about sort of complete obstruction. And if they're sort of, still there, high tinkling, then it's more likely with small bowel obstruction. Okay, so investigation-wise, we'll ask you guys about this all here. So you have your basic investigations, which you more or less do on every patient that comes through. Your bloods, you check for any signs of infection with white cell count, neutrophil, CRP, LFTs just to exclude any capillary causes or any obstructive jaundice. Amylase, very important. It is used, with pancreatitis. It's more or less very sensitive. If it's 3 times the greater, 3 times the upper limit of normal, more than 1,000 basically for pancreatitis. But amylase can be raised in sort of, a lot of conditions, a lot of inflammatory conditions. So if someone was to ask you on the exam question, serum, what would you otherwise use for, if you didn't want to use amylase, what's a more sensitive indicator? Yeah, that would be okay. So, yeah, as you can see, 2 to 3 times the upper limit of normal. You might be thinking of any other causes. Right. Okay, as I said, FHCG, excluding ectopic pregnancy. ABGs, in the clinically sick patient, they're just essential. You need to do an ABG. That's the one thing that I probably learned from that is very useful and is always asked by the doctor. You don't give it their answer. Any reasons why? What does an ABG tell you? Yeah, lactate, what would lactate be an indicator of? Ischemic bowel. And the level of acidosis as well in surgical patients. NSU, rule out UTI, any blood on urine dip. PCG, concerned about MMI, and chest X-ray we always get. It says it here, but can anyone just point out where the abnormality on that direct chest X-ray is? Which type? Right. Yeah. Brilliant. And with erect chest X-rays, we just look at the basal lung, for instance, consolidation, any loss of the right or left heart borders, the angles. Abdominal X-rays, they're usually very quite difficult to interpret. Radiologists have a hard time doing it as well. Essentially, at our stage, you're looking in terms of obstruction, any fecal loading, any cause why the bowels are not, moving on. So, just to highlight in red, the ischemic valve, what you would see on abdominal X-ray is sort of featureless valve, edematous valve, which has lost its, depending if it's small or large valve, has lost its features, which are the, well, I'll actually ask you, what defines small valve on an abdominal X-ray? How would you differentiate between the two, small and large valve? Yeah, small, yeah, there will be a lot, but where would it be? Central, yeah. And anything else? Yeah, what are those lines called? Yeah, valvular something, that's right. And the large valve will be partially crossed over by those lines. So, and another thing is renal stones as well. Sometimes you can see it made of calcium oxalate, but you see the renal stones within the ureter stent. So, diagnosis there as well. So, any other investigations? So, those are your basic investigations. Things from the outside. That would be the ultrasound scan, very commonly used. You know, for if you're right upper quadrant pain, anywhere really, if you want to rule out gallbladder pathology, ovarian pathology, trauma, just liver or the spleen. In A&E, you can do the FAST scan. I haven't seen it being done, but I was talking to one of the regs, and he basically said that those FAST scans are pointless, really. And what ends up happening is that they get a CT scan. Anyway, so I don't know. There's something to look into how specific the FAST scan is. And OGD, throughout any esophageal pathology. And the last one, which I haven't mentioned, would be intravenous urogram, just to have a look at the kidney, the ureters, and the bladder. All right. And then this is the investigation of choice for surgeons when they're pretty much stuck, or sorry if anyone wants to be a surgeon here. A lot of consultants, you will find that some patients can be quite tricky, and they'll complain about abdominal pain, and then what will happen is the consultant will just ask for a CT scan, and we'll come back to normal. But you shouldn't obviously, that's where you get working. For your focus on exams is it's an investigation approach for trying to find the cause for abdominal pain, and it can show up AAAs, pancreatitis, diverticulitis, malignancies, metastases, pretty much everything. Okay, so resuscitation-wise, the patient was for a patient and the parasympathetic, what would you do except focus on your health? Yeah, ABG, yeah. ABC, okay, yeah, brilliant, yeah. That's how, yeah, sorry, on the side. What would you give them? Fluids, yeah. Anything else? Antibiotics. Yeah, you checked they're on antibiotics already. What else? They know by now. If they're obstructed, then think of an NG tube and you can press the stomach. So ABC, ABCDE will literally be your mantra for F1. Give them oxygen, fluid resuscitate, IVI, analgesia, and take bloods and put a catheter in. So when you're putting in the cannula to give them fluids, take bloods out of that. And if you can't take an ABG, just take a VBG. The only difference is oxygen. Yeah, so they would commonly if they were very acute and they're hypotensive, at least give them fluid challenge. If they're not, then I will probably hold off, and their odds are otherwise stable. I'll hold off the fluids, keep an eye on them, get a VBG, see the lactate. If that's high, then give them fluid. And the catheter would be to measure urine output. IV antibiotics, broad spectrum. Surgeons, they love coamoxil tablets like bleach for bacteria. Analgesia and surgery, depending on whether it's indicated really. So, as I said, I'm not going to cover everything in this talk. There's just two conditions that I've seen a lot of, and to be honest, I don't really have time to go into anything else, so sorry about that. So, acute pancreatitis, we're just going to talk a bit about that. Inflammation of the pancreas, just from the name. Chronic pancreatitis, long-standing. Etiology, you guys all know, get smashed. So, gallstones, alcohol, two most common causes. Trauma, steroids, mumps, infection, autoimmune, SLE, scorpion bites, snake bites. I've never seen before, but exam question there. Metabolic disturbances, hypercalcemia, hypothermia, high lipids or low temperature. ERCP, that is a fairly common cause of pancreatitis. Patients who have ERCP. And drugs, steroids, one of which diuretics. So those are the causes of acute pancreatitis. What happens in pancreatitis is that the pancreas starts to eat itself, basically. All the enzymes that it produces comes out, and it basically digests itself. And the worst kind is trypsin. There's three types of pancreatitis: increasing in severity, edematous, hemorrhagic, and necrotic. Edematous usually you can treat with conservative management, which is fluids and antibiotics and analgesia, whereas hemorrhagic and necrotic would definitely be on HDU at the very least, if not ITU, and those patients are very, very unwell. So clinical features, you guys all know this: epigastric pain, raising to the back, nausea and vomiting, fevers. Literally, that's your history there. Signs, they can be but it's just important to take a note of the odds and see if there's any tachycardia or hypertension. Peritonism in the upper abdomen, so it could be localized, it could be generalized depending on the severity. Gray Turner sign, usually a very late sign, and it's going into the natural upper leg. This bruising that you can see there, or Cullen sign around the umbilicus. And that's seen in hemorrhagic, because the blood vessels that supply the pancreas are damaged and they're bleeding out. So that's Cullen sign, and that would be Gray Turner sign. I've never seen that, but I've only been working in follow for 2 months. Differentials for upper abdominal pain. So other differentials for pancreatitis would be gallstone disease, peptic ulcer disease, and again, just to make sure always keeping back in mind AAA. Investigations-wise, as we said, all those investigations I mentioned before, and as well. X-rays, just to rule out a perforation, have a look at the bowel, is it distended or not. An ultrasound, yeah, that can be done to look for gallstones, but not very, haven't really been seeing it, been asked to order an ultrasound for pancreatitis if it's just very mild. And then the investigation of choice, you see the abdomen, they're not settling down, only after 2 hours, sorry, 2 days. I'm not too sure why it's only after 2 days of the symptom onset. Maybe it's just to allow the pancreas to sort of settle down so that they can get better. I'm not too sure. MRCP, which is the MRI of the biliary tree, if there's just to confirm that there's gallstones, and then that would be followed up with an ERCP. The hospital where I work at, they always ask for an MRCP just to confirm the diagnosis of gallstones, to make sure that it's there. Can anyone tell me why that's asked for? Sorry? It's not invasive. What are gastroenterologists concerned about when they do an ERCP? Perforation and there's risks associated with that. The other one would be pancreatitis, as you mentioned before. So, and the perforation would, they would have to ask the surgeons to come and help them. So it's another reason why.
What are you worried is going to be perforated?
So the duodenum. when they go out and fish the water, there is a risk of filtration. They want to be absolutely sure before going ahead with any RCP. So, what's the scoring system for pancreatitis? So, essentially, oxygen, age, so hypoxia, greater than 55 years, high white cell count, low calcium, high urea, is dehydrated, enzymes, LDH, and the LDH during the LFTs, albumin, which again would be off the LFTs, the BM. So, you know, most of those things you'll find out. The only things extra that you will need to get is LDH and albumin, as for BM. A score of 3 or more would warrant a trip to HDE at least. And a CRP is a very good indicator of severity. If it's greater than 200, you should be fairly worried. The other scoring systems I don't know too much about, but I assume that they're similar to the modified Glasgow score. The other one would be Radisson criteria. So management, I mentioned this before, ABC, 4 principles, IVI, catheter, strict fluid monitoring, analgesia, give them rest. You wouldn't say, you know, have a normal diet, say, lay off the spicy food or and the fatty foods. And if they need any other support, then the ultimate would be TPN, which would be to give everything through the veins. And determine the underlying cause why they're having why it's pancreatitis. So most of it, they settle down with conservative treatment, which is the above IVI and antibiotics. If it's severe, then there will definitely need to be, you know, it's not ward-based care. There needs to be something higher. That is controversial. I'm not too sure about that. We give them antibiotics. I don't know. Sorry about that. It says they commence with necrotic pancreatitis or infected necrosis, but not routinely. Sorry, I don't know. And surgery is only very really required. In terms of the complications, hypoglycemia, hyperglycemia, systemic inflammatory response syndrome, the spiking temperatures, acute renal failure, usually dehydration, ARDS, respiratory distress syndrome, DIC, you know, the coughing would be affected and basically bleeding out from everywhere, and which would go on to multiple failure. And that they would be in ITU, you know, they should be in ITU long before that happens. Right, so just a quick overview of SIRS. Does anyone know what this is? Come across it before? Yeah. So what are the 4 criteria for SIRS? Yeah, that's right. Anything else?
The temperature.
Yeah, temperature. Heart rate and respiratory rate are the other ones. And you need 2 of those to say that it is. So, okay, so temperature, the hypothermic or arexial, tachycardia greater than 90, respiratory rate greater than 20, and white cells greater than 12. So if you require a patient was scoring on 2 or more of those, you have to implement the sepsis 6, which is what we talked about. Have you guys come across sepsis 6 there? So as I mentioned, the complications, ARDS, renal failure, DIC, renal failure. So it can be infective SIRS or it can be non-infective in origin. So basically it's just an inflammatory response, and it can be, again here, acute pancreatitis, trauma, ischemia. So local, the complications of acute pancreatitis, necrosis, as already mentioned, an abscess forming, pseudocyst, hemorrhage into one of the vessels that supply the pancreas, thrombosis of the spent vein, and consequently ischemia. small bowel venous congestion, ischemia, and chronic pancreatitis as well. So in necrotic pancreatitis, that's a severe end. It's treated with antibiotics, and an abscess can form from that. Okay. So again, it's very severe, and mortality rate of 50% due to the high risk of cells progressing into things we mentioned, renal failure.
Do people tend to be left with diabetes after having bad pancreatitis? They should get away with it.
This depends on how severe
Yeah.
pancreatitis is. They do get over very traumatic and very severe case of pancreatitis. It's mild and so infected necrosis, antibiotics and surgery to exercise the necrotic tissue. Abscess, I've already mentioned, essentially it's a collection of pus which would need drainage, and it would present a few weeks after the initial attack of pancreatitis. Yeah, so it can be either surgically drained or you can ask interventional radiology, which surgeons do a lot of. They liaise with interventional radiologists to drain collections that have occurred post-operatively. So pseudocyst, it's usually a fluid collection within a fibrous capsule. It's a long-term complication. Most of the time you don't have to do anything for it. If it is symptomatic, there is compression of the surrounding structures, it's called the CBD, causing obstructive jaundice, or the duodenum, which would be small bowel obstruction, or if it becomes infected, and then you need to do something for that, which would be drainage. Again, can be done under radiological guidance or interventional, endoscopically or surgically as well. Okay. Chronic pancreatitis, long-standing, and it presented as acute inflammation, previously damaged, so acute and chronic, so it's chronic. You need pancreatic insufficiency, malabsorption, and diabetes. So clinical features, again, upper abdominal pain, weight loss, steatorrhea, offensive smelling stools. Differentials would be, obviously, chronic pancreatitis, biliary obstruction, so CA, malabsorption due to small bowel disease, Crohn's, celiac disease, drugs, orlistat. Yeah, so orlistat can also be differential for steatorrhea. Okay, so chronic, as I mentioned before, alcohol abuse, chronic NSAID use or steroid use. No causes found 25%. Cystic fibrosis, most common cause in children. Also on the rarely cause chronic pancreatitis. So that's this is just repeating what I've said before. Amylase and lipase is often normal because it's chronic. Okay. You can measure the fecal elastase. Okay. And secretin simulation test and gold standard, but I haven't come across that before, so I don't really know what to say on that. Look it up. Sorry about that. Don't want to check if any signs of any areas of complication, and CT if you're worried. So again, conservative management, analgesia, treatment of secondary diabetes that as a result, and any malabsorption, so pre-on and nutritional support. So surgical intervention is extremely rare. Sorry. The last thing we're just going to talk about is intestinal obstruction. So that's defined as any obstruction to any bowel contents going through, classified as small or large, complete or incomplete, or mechanical or functional. So mechanical would be a physical blockage, functional would be something like post-op IBS, so the bowel's going and strike there. One caveat to mention is closed loop obstruction. So if you have a competent ileocecal valve which closes in on itself and the large valve becomes obstructed, the large valve will just balloon up, and because there's no escape for the gas there, and that would be, you see that very easily on abdominal X-ray. So just avoid in mind 20% of the population of competent ileocecal valve. All right. Anyway, so mechanical bowel obstruction, the causes, common causes you mentioned, one, adhesions. What are the others? Any other? Sorry? Any other causes? Interception, yeah? Yeah. That's all right. So just categorizing it, can be within the lumen, outside of the lumen, or within the wall of the lumen. So adhesions and hernias are the most common causes. Interception, like you said, Crohn's disease, any metastatic deposits, or Gauthieron-Itis. Large bowel, sigmoid bowel, volvulus, and cephal volvulus, you can see on abdominal X-ray. Foreign body, impacted feces. It's just important to bear in mind adhesions and hernias are a rare cause of large bowel obstruction. So essentially, it's very easy to understand obstruction to the bowel. The bowel therefore fills with fluid and gas. There's bacterial overgrowth, so you get a distended abdomen. When the pressure within the lumen becomes greater than the pressure of the capillaries in the blood supplying that area of the bowel, when that exceeds the capillary pressure, leads to ischemia, and therefore into gangrene and necrosis, and then perforation, and then okay. Features of intestinal obstruction, as I mentioned before, colicky, abdominal pain, extension, vomiting, and obviously constipation. If the obstruction was at a high level, near the gastric outlet, then you would see, virtually no distension, a lot of vomiting, and absolute constipation very late, and that would be reversed if it was distally, the system was distally obstructed. So this is what you see: distended abdomen. You look for any visible peristalsis, any scars from previous surgery indicating adhesions. Palpate the abdomen can be soft, depending on the degree of obstruction, and also just check for hernial orifices, just to check for any hernias. Right. So the investigations, again, more or less the same, apart from contrast studies. The contrast studies will give you an idea of where the obstruction is. They won't give you the cause of the obstruction. So usually the CT is asked for if there is obstruction, occasionally defined on the contrast study. We were mentioning about before small bowel and large bowel. Valvular congenitally completely transfers to small bowel. There's the large bowel, it doesn't. 3.5 centimeters for small bowel, anything greater than that, and for large bowel, greater than 5 centimeters. Okay, so on the left, that's small bowel. Two reasons why. The valvular congenitally coming across and centrally distended and loops of the bowel, whereas it's the opposite on the left for the large bowel. So conservative management for obstruction would be drip and suck, fluid resuscitation, and NG to decompress the stomach, nail by mouth and analgesia, and obviously using the ANC approach as well. Okay, so that's all I'm going to talk about. I'm just going to run through quick questions. So, which of the following is not a typical feature of acute appendicitis? So, refuse vomiting when possible. Sorry, I didn't catch the answer. That would indicate more gastroenteritis. A low-grade pyrexia is just something also to be aware of. If they're spiking very high temperatures, it could be an abscess, some appendicitis. Right. So, what is most likely electrolyte abnormality? Patient with diarrhea and soft mass. PR. Why is that? Yeah. Yes, that's one cause. The other cause, a rectal adenoma, rectal villus adenomas are high. They secrete villus which are rich in potassium. So, 44-year-old lady recovering from transperineal mastectomy, unfortunately is post-operative hemorrhage. Which of the following features is most likely to occur initially? Why would that be? Did everyone get that? Yeah, so it would be C, because the operation is going towards the pituitary gland, which lies on top of the optic chiasm, where the optic fibers decussate partially, medially they decussate, the lateral must continue, so that will give you a bitemporal on this Pinocchio. So your right and left visual fields. So in the right eye, the right part laterally, and the left eye, the left visual field laterally. Okay. So 59-year-old presents with recurrent episodes of urinary sepsis. Has suffered from recurrent attacks of left iliac fossa pain over the past few months. There's also noticed bubbles in his urine. Undergoes a CT scan which shows a large inflammatory mass in the left iliac fossa. No other abnormality is detected. The most likely diagnosis is anyone have anything else? The colleagues wrote diverticular disease. Things in the history, just to note, the left iliac fossa pain, diverticular would be right up there. Bubbles in the urine, so there's a connection between the colon and the bladder. The colon is fistula, which is common with diverticular disease, and the mass in the left iliac fossa. There's nothing else to indicate, it could be a rectal CA in the history. That's given. So which of the following disorders are most classically associated with ulcerative colitis? Okay. And what would be the antibodies that you want to check?
Mitochondria?
Yeah, it's mitochondrial, right? Okay. So, 75-year-old man is admitted with sudden onset severe generalized abdominal pain, vomiting, a single episode of bloody diarrhea. He looks unwell, uncontrolled AF, although diffuse pretended his abdomen is soft. What do you guys go from that? Okay, yeah. Mesenteric, which one? Infarction. Okay, yeah, that's nice. What makes you think from the information given?
Sudden onset pain, past history of AF.
Yeah. Okay. Next one, 19-year-old, no abdominal pain, diffuse pretender, multiple fine adhesions in nose, between the liver and appendix.
Yeah.
Yeah. Okay, and the next 78-year-old man develops severe back pain and collapses, low blood pressure of 90/40, high heart rate, abdomen distended and disease, low tenderness, abdomen soft. Result. The back pain, right, coming towards the end. Why is that? And the findings on right, 70-year-old female, history of passing brown coloured urine and abdominal distension, features of large bowel obstruction, central abdominal tendons, tendon in the left iliac fossa, and so what would be the most appropriate stage? Go for CT. The reason being is she's elderly, and you want to just find the cause of the obstruction, which the main thing you'd be wondering is MECA. Next one. 47-year-old alcoholic, central abdominal pain, first sit-up, has the pain aggravates online, and eating, high heart rate, high x-ray. So, acute pancreatitis, Herrick, umbilical discoloration. Okay, so this one, 53-year-old, diabetes, hypertension, undergoes uncomplicated AF rectal CA. 3 days afterwards, faintness while walking to the toilet, low blood pressure, high heart rate, tachycardia, saturations are normal, and BM is high. Which of the following is the most appropriate immediate investigation? What do you think? Chest X-ray. Anything else? Okay. The person who said chest X-ray, what's your line of thoughts? Okay, that's a possibility. You would do more or less all of those things. The most appropriate immediate investigation would be an ECG in this case, just from the wording of the question. So the diabetes, although it doesn't complain of any evidence of pain, it would be the quickest thing to do. And you don't keep on doing things, but it would be the quickest thing to ask for in that case. So Emma, science. 70-year-old, sudden onset epigastric pain, lowish blood pressure, high heart rate, passing the history of OA, abdominal radiograph is normal, perforated, so gas under the diaphragm on the direct chest X-ray, and PR showing VNet. Would it be perforated? That requires urgent attention. Right, so 42-year-old asymptomatic woman undergoes an abdominal ultrasound scan, which shows gallstones. She's the first surgical outpatient, and what is the treatment of choice?
No treatment.
Yeah, that's right. She's asymptomatic. Yeah, essentially. Okay, I think this is the last one. So, 35-year-old who has Crohn's, undergoes a terminal artery resection. Which of the following conditions is least likely to occur as a result of this operation? So you can reverse the question and say, well, what does occur with Crohn's? As the answer, yeah, everything else would, subacute combined degeneration of pancreas, wouldn't expect that, but within B12 would be affected. Okay.
Why is that as a result of the operation? Why is that a result of an operation to get subacute combined degeneration of spine? But like as a result of the operation?
Yeah, so you say things like how they can't absorb the child.
It would be an unlikely and long term.
Why do you get those then?
Your bile salts aren't really good as well.
So that's all. Thanks for coming. We'll let you guys know when the next